Hey everybody, welcome back. The Doctor's In Live with TOA is back. It's Monday, Murfreesboro Monday. You see a familiar face here if you tuned in before. This is Jimmy Phillips, one of our senior super duper physical therapists, and he's here to talk about some really kind of interesting stuff more than just physical therapy in general. I hope everybody did okay with the snowpocalypse. I actually like the cold weather, and hopefully nobody got hurt or got their cars hurt or their kids got hurt. But it's gone now. It's Middle Tennessee, so it's gone by. Anyway, I'm Gray Stallman. I'm your host. This is the Doctor's In Live with TOA. This is our opportunity to give back to you and give you some information about us, about TOA, about musculoskeletal health and care in hopes of helping you deal with the ravages of time, age, and general bad behavior or bad decision making. As with all of our episodes, please remember that while I'm an orthopedic surgeon, this gentleman here is a physical therapist. We are not your practitioners today, okay? We're just giving you some information. Consider this for educational and informational purposes only. If you have any type of musculoskeletal problems, bone, muscle, joint, nerve, pain problems, and injury, go to TOA.com. You can learn all about TOA, the largest orthopedic surgery practice in the mid-state, soon to be the largest orthopedic practice in the state. We've been here since 1927, and we will be here until 2027 at least, I'm suspecting. Maybe 21, 27. Anyway, look at TOA.com. There's a whole load of information about our practice, our practice practitioners, where we are, what we do, and we can help you. So please go to TOA.com. Anyway, without further ado, Jimmy Phillips, good to see you again. Thanks for being here.
It's good to be here.
We talked last time about physical therapy and kind of what is physical therapy and the role of training in physical therapy and whatnot. You wanted to talk a little bit about today about some of the tools you have in your toolbox to try to help people, right?
Right.
So anybody who's had an injury, surgery, orthopedic surgery, many of you have had physical therapy, and there's a whole variety of things that can be used to try to help people improve their function, decrease their pain, and feel better.
Right.
So give me an idea of kind of your list, your laundry list of things you work with patients.
Well, in our setting, it really is setting specific. In our setting, dealing with orthopedic patients, Tennessee Orthopedic Alliance, we are most skilled, I think, at taking care of folks that have bone and joint issues from the head to the toe. So in our situation, we run into a high percentage of patients who've had surgery. The therapy content for those folks is pretty heavy exercise. Now, exercise is a broad term. There's a wide variety of things we utilize, from stretching to strengthening to balance to stabilizing. I mean, depending on the deficits that our patients are dealing with and their proximity from surgery, if they've had surgery, from injury. Otherwise, that will determine what exercise we utilize. We are fortunate to have good communication with our doctors. We have access to patient files, their charts, so we know the do's and the don'ts, so to speak. There's, depending on the surgery, there can be a whole lot of don'ts, things that are unsafe to do, contraindications, precautions in those recoveries. And again, essentially for us, rehab protocols that we often utilize are dictated by what those precautions are. And then as people recover, they get further out of surgery, their fractures heal, their ligament reconstructions get stronger, then obviously those precautions are steadily taken away. Those timetables are dictated by our referring physicians, and then we just kind of work around them depending on what's appropriate. So as I say, that's wordy, but therapeutic exercise is usually a huge part, the biggest part of our therapy interventions.
Yeah, that's been my experience, and I think having our group of therapists, who are top-notch, by the way, have the ability to not just slap on a boilerplate model of treatment. There are actually treatment protocols that are specific by surgeon for specific problems in many cases. Really makes that experience, I think, even more beneficial to the patient rather than, okay, well, this is what we do for every shoulder replacement I've ever seen, we'll do it the same way, and that doesn't necessarily work for each individual problem. So I think that's a big plus with the system we have in place.
Absolutely, absolutely. Again, for us, I've been in a situation, once upon a time when if I'm across town and I get this referral, somebody calls in at whatever physical therapy office, I don't necessarily have access to that information, and getting it can be a challenge sometimes. The other part is being able to communicate with our physicians, problems that people are encountered. Okay, so if my rehab protocol says, all right, at week 4, I'm allowed to do squats or whatever exercise, but a person can't lift their leg without a bend in their knee, they've got an extensor lag, their quads are so weak, well, probably isn't appropriate to do that exercise, So just because it's written on some piece of paper that someone decided was safe, it doesn't necessarily mean it's a good idea for each patient, because you see different rates of progression. So there's individual variability too that might determine implementation of these rehab protocols. Maybe you need to decelerate a little bit because someone's just not ready. So.
Well, I've definitely had that experience in my practice where a lot of people come in and they say, well, can't you just give me a sheet of exercises to do? Do I have to go to the physical therapist? And my opinion has always been it's far better to learn from an individual that can observe, that can give you feedback, rather than try to just sort out a page of exercises. I found that generic stick figure exercise sheet, while typically not terribly harmful, is probably not terribly beneficial. And so it's always worth it to at least go to the physical, and I'm talking not about surgery, I'm talking about just general rehab for I threw my back out or something like that. At least go to the therapy one time so they can work with you, assess you, and kind of create for you a home exercise program. So you can go one-on-one with an educator and get that information for yourself. I think that's extraordinarily important.
Well, I think the education part is key too, because if I give someone an exercise or a group of exercises, I really should be able to tell them why they're doing those exercises.
Yeah.
Whether it be using models to explain what Dr. Stallman might have found in an X-ray, disc degeneration, vertebra closer to one. There's lots of ways that we'll explain to patients, and we'll see light bulbs come on. They understand why they should do these things and maybe why they shouldn't do others. Because if you can get exercises on the internet, and a patient might, Google disc degeneration and get exactly what they need.
Right.
Or they might Google disc degeneration and get things that are going to cause that shooting pain down the leg to intensify, into weakness, more extensive issues. So, being able to spend a little bit of time, we have the luxury of time in physical therapy where we have, blocks of time where we can really talk to them a lot. Our doctors are on a much more stringent time schedule. We have the luxury of time downstairs, and it's helpful to talk about the why, is what I like to say. Well, why? Here are these exercises. Why should I do them? Why should I not do others? The education piece, I think, is key. So.
And then the obvious, real-time feedback that you get. You're the one you're the boots on the ground, seeing what that patient is going through every other day or every third day or something like that, whereas the doctor may see the patient every 6 weeks. And so that real-time feedback is really important.
Right.
Yeah. So, therapeutic exercise, which includes stretching, range of motion, flexibility, strengthening, all these things. It's not just running on a treadmill or sitting on an exercise bike, as far as exercise goes, is really quite clearly the mainstay of what therapy does to try to help us get everybody where they want to be.
Right. The active portion, I call it the meat and potatoes.
That's right.
We do dessert, but
that's the blue plate special.
That's right. And we need dessert sometimes, but
we always need dessert. That's right. So speaking of dessert, what are some of the other options that a patient may experience rather than just an exercise or stretching or strength training that they might see or experience when they come to you in the office?
We'll use what's generically called modalities. There's a wide variety. Historically, kind of the main things we've utilized: heat therapy, cryotherapy, which is cold therapy. There's different forms of that. Heat can be in the form of a moist heat pack. Once upon a time, people used shortwave diathermy. Pretty sure I've never seen that since I've been a graduated physical therapist. But a hot pack is the more common form of heat that we'll use. That's more of a superficial heat. Cryotherapy would be ice. It could be in the form of just a cold pack, a bag of ice. Could be in the form of like an ice bath, like after ankle sprains. A lot of our old coaches, if they had a football, basketball player that sprained their ankle, they would make them dip it in ice water. Not a lot of fun, but probably pretty effective for acute injuries like that. Nowadays we have things like game readies that are kind of combine compression with cryotherapy, with ice therapy. Really pretty nice tools. Probably not essential in my opinion to what we do, but there really are. Patients might differ with that. They really enjoy it. Those are cold therapies. Other things we've utilized historically: ultrasound. Ultrasound, not trying to see if you have a boy or a girl. Therapeutic ultrasound, which is a deep penetrating heat, can provide some relief. From a pain standpoint, can serve as a role of stimulating blood flow, to promote kind of a healing effect. You can combine ultrasound with medication. Usually we use dexamethasone. That process is called phonophoresis. People that have more superficial, like tendinous type problems, we'll see it. Tendinous like rotator cuff tendonitis of the shoulder, tennis elbow, golfer's elbow. We'll use it for hip bursitis oftentimes. Achilles tendonitis. It's just another tool that can be helpful from the standpoint of promoting healing by stimulating blood flow. Also happens to feel pretty good because it's a deep penetrating heat.
And those things, the phonophoresis, that you're trying to actually use the ultrasound to essentially drive that steroid a little bit deeper into the tissues.
That's exactly right.
So that the anti-inflammatory effect can also play a role in trying to help heal that itis, that inflammation problem.
Right. It's an alternative, and I'll tell my patients it's the analogy that I think they usually are comfortable with. It's kind of like getting an injection without the needle. Okay, now do you get the same degree of medication delivery? No way you can do that. But there's certain areas that you just, as a physician, you can't inject. Achilles tendons. I don't know all the whys on that, but I know that that's something that I think there's safety concerns of injecting certain areas. Well, it's an alternative. Mm-hmm. It gives us something external that we can do. Also, needles aren't really all that fun,
right,
if you're the one that's on the receiving end of that. So it's something that you can try prior to higher levels of intervention. Which oftentimes is helpful. It's not 100% of patients don't benefit from these things, but a lot do. So it's worthy of trying for folks that are especially trying to go the most conservative route, as long as it's appropriate.
So I get a lot of questions about, doc, should I use heat or ice? And I know this is kind of a divergent thing, but give me an idea of when you would use heat versus ice in somebody's treatment plan.
Heat typically is more chronic. Okay, so if I've injured my back and I've dealt with it, or I've had a back issue, not even an injury, we'll take that example out, but if I've had back problems, they've kind of been nagging for a while, they're progressing, finally I've decided to do something about it. Well, that's an example of more of a subacute chronic type scenario where there's not really going to be a negative effect to heat. I guess like anything else, you don't want to necessarily do it over and over again if you're not getting consistent, significant relief from it, but you're not going to do any bad. Walking to the parking lot this afternoon, if I happen to step off a curb and I sprain my ankle, well, usually with that injury, you're going to have acute swelling, you get some capillary tearing, you have bleeding, and that's what produces that swelling. Well, I would want to wait several days before I consider putting heat, so ice is my alternative at that point. So, to sum it up, kind of an acute issue, we want to stay away from heat for a few days to let things kind of calm down, to allow those capillaries to heal, or the heat can have the ability to expand that swelling. When it's an acute problem, then you want to stay away from heat. For my patients that have had shoulder surgery, they've had knee surgery, whatever, we offer heat and ice depending on the person, depending on their comfort level or discomfort level. The folks that we usually will stick with ice for the first couple of weeks out of surgery because we've had incisions, those incisions are healing, we feel like that might heat stimulates blood flow to an area, so there's the potential that the heat could expand that swelling, which of course we don't want. So we'll stick with ice. Beyond that, we'll use whatever they feel most comfortable, whatever gives them the most relief. Because our goal long term would be more comfort than swelling or stiffness or whatever.
Yeah, and I would imagine, particularly after surgery, but after a therapeutic exercise, which can, particularly in a surgical bed, can increase inflammation. It can increase irritability of the joint. Icing it down afterwards is kind of a preemptive way of reducing the effect of that therapeutic exercise with regard to the negative effect, the discomfort, the swelling, the tightness, and things like that.
Absolutely. And even people that don't traditionally like ice, I mean, there's not very many people I run into that do not like heat. I mean, I'm shocked every time if I ever hear that conversation. It's like once every 2 years. Not every guy likes ice, but it's usually really soothing with an acute injury or right after surgery, in the acute phase of recovery after a surgery. People usually are getting comfort, which is more my motive. I found with the stuff we see, whether it's a knee replacement, there's a lot that goes into replacing a knee in terms of surgical trauma. I mean, there's a big incision and there's bones that we won't even go into all that. But that said, healing has to occur for the swelling to go away in that case. My motive, and that's just what I'll tell folks, is for the ice is not as much necessarily about the swelling in that scenario as more the comfort. It just feels good.
Yeah.
So that's a way that people can achieve some degree of comfort without it being medicinal, without it being medication. It kind of links together, maybe when they're supposed to take the next, pain pill or whatever. It kind of gives them some relief in the meantime. It just tends to soothe. So.
And I think people really need to, except for very few cases when you've had an injury or surgery at home, or an injury at home, you're not going to hurt yourself by using one or the other. I always tell people, use whatever feels better. If you've tried heat and it doesn't seem to help, you want to try ice, it's okay with me in the lower back. Now there are some times when we wouldn't want to use aggressive ice therapy on a post-operative type of situation, like really thin tissue that doesn't have a robust blood supply. You can, like, around the fingers and hands, sometimes that can be a problem because if you ice that too much, the blood vessels contract and now that tissue doesn't have any blood flow to it, and it can actually lead to necrosis or tissue damage. So that's one of those things where the surgeon and the caregivers need to be involved with saying, okay, ice is great here, but not here, and things like that. But the simple bumps and bruises, aches and pains, strains and whatnot, the bread and butter of what we do for a living, you can't go wrong with either, really, in my opinion. So that's the simple stuff. We could have been treating everybody outside, rolling around in the snow this week. What other kinds of things might you offer to a patient, and why?
Well, electrical stim is another one that a lot of people are familiar with. There's a lot of folks who have had back issues that have utilized a TENS unit. That's basically a home version of what we do. It's another tool. It's utilizing electrical stimulation to ease discomfort. We use electrical stim for pain relief predominantly in the clinic. We'll also use it for muscle re-education. Someone who's had a surgery, a lot of times any kind of knee surgery, they really have a hard time getting their quad muscle to fire. The muscle that straightens their leg, that lifts their leg, that gives them stability predominantly when they're standing. So we'll use electrical stim to activate muscles, to cause a muscle contraction to aid in the strengthening process. As I say, we'll also use different waveforms of electrical stim for pain relief. TENS would be most commonly used at home. Those are little bitty units. You can put it in your pocket, put it on your belt. Electrodes go to where the area hurts. Very common for low back pain. In the clinic, there's interferential and there's pre-modulated. They're different waveforms. Not really important.
You have to be an electrical engineer to understand them, but
or something like that.
Yeah,
but it's they're alternatives for comfort. For pain relief. We have a lot of folks that come in that are in a pretty good amount of pain in the early going. Hopefully they get rid of that through our rehab process, but they can come in some pretty significant discomfort, and that allows for some some relief, as they go through their day. Most of these, like the modalities, maybe the exception, we talked about phonophoresis, and ultrasound in terms of having some healing properties. I would say the limitation in most modalities is they're not necessarily, if your aim is pain relief, they're not necessarily going to sustain that relief. If I put ice on my knee or my shoulder, probably going to feel better for a while. Or heat, same idea. They're not necessarily going to produce ongoing relief. You use these other things that we utilize, the therapeutic exercise, our hands-on types of things, usually are the things that get us to that sustained ongoing relief and takes away the need for the modalities.
Well, that's a great comment, because in my experience there are a gazillion physical therapists, chiropractors and whatnot out there practicing on people, and unfortunately I believe that the mainstay of long-term benefit is therapeutic exercise and type of manual therapy. The modalities can be an add-on, but they make you feel good for a little while, but once they're gone, they're not creating a long-term effect. And a lot of people spend a lot of money going to the physical therapist or the chiropractor, and by no means am I bashing either physical therapists or chiropractors, okay? But the therapy that they receive is modalities only, which is a feel-good at the moment type of thing, but unfortunately it's really not addressing the more root cause of the problem, which is muscle strength, muscle flexibility, muscle balance. It's expensive to go to the physical therapist every time, and so you might as well get the best bang for your buck. So I think in our system here, we utilize the modalities, but they're a tool to add on to the mainstay of what we do, which is the manual therapy and the therapy and exercise.
Absolutely.
Yeah. And then I'm looking at your little list here. I see dry needling, and a lot of people have heard of dry needling. It's a rather new technique in this country anyway. Tell me about that, what you know about it, and where it has a role.
Right. Well, and it's another tool for pain relief. In our office here at Murfreesboro, we have 2 therapists that are certified in dry needling. I'm not one of them. My disclaimer there. But that said, we have patients that come in. It's essentially trigger point therapy. So oftentimes we'll have folks that come in predominantly with spine issues, sometimes shoulder, that can prompt some of those knots that you might feel as you run your hand up and down your neck and back. You can use them in other areas of the body, but I'm saying most commonly that's the area that we're gonna treat folks with those problems. Maybe those things haven't responded to traditional massage, ultrasound, some of those other things that we will utilize that will help to kind of ease that stretching. Dry needling is an alternative for that. In essence, it's a needle, and they actually use acupuncture needles. So that's a little less invasive to the tissue than a traditional needle, like one of our doctors would administer an injection with. But they're actually going into the muscle. So they're going all the way down into the affected muscle, and that needle helps to resolve some of that spasm, that trigger point. My understanding with acupuncture kind of difference is acupuncture doesn't go into the muscle. It's not as deep, and that's not saying it's less effective. Patients get really good results with acupuncture. It's just a different method.
I think they're kind of kissing cousins to one another.
Absolutely.
They're approaching different tissues.
Absolutely.
And my understanding is that in part you have a needle going into a tissue, and it's actually creating some microscopic trauma, which can then stimulate your body into a healing mode, and kind of again bring blood flow to that area to try to release those contracted, and knots and spasm are basically muscles that have contracted into localized areas that are not released, and the muscle fibers don't like that. When a muscle contracts and stays contracted, there's a bunch of chemicals that are released essentially as a result of that process that is irritating to those tissues. So it cycles and it keeps up with the same inflammation or same irritation. And so what you're trying to do is really break the cycle of that chronic spasm in that area.
Yeah, pain, spasm, pain cycle. You have pain from, we'll use the neck example, from disc degeneration, disc bulge, whatever. Usually there's a muscular response, which is to go into some degree of spasm as kind of a protection. That's one thing that prompts tightness, stiffness, limited motion. Sometimes that's mechanical, the anatomy of a joint as we age. Sometimes it's those muscles that are in a state of spasm that in turn produces more pain. So pain, spasm, pain, breaking that cycle is what it takes to get comfort, to get relief. So.
Right. And then anything else out there? Is there
traction?
Traction.
A lot of people are familiar with decompression. You'll see that in various advertisements and whatnot. I see that term more used by chiropractors. Traction and decompression are very similar. Decompression's a little more specific in terms of the actual machines themselves that they're utilizing. Right. That's exactly right. Maybe you can pinpoint a specific segment. If I've got issues at C5, C6 in my neck, it's a little more specified. Whereas our traction machine, we do cervical traction, we do lumbar traction, and it kind of stretches everything. So folks with disc bulging, disc degeneration, etc., most of those folks are candidates for traction, which kind of helps to nourish the disc. In essence, it's kind of stretching out. You might also kind of throw inversion. People a lot of times will have inversion tables in their home as a way to do home traction. That's not for everybody. It's kind of different going upside down, but that's what we're talking about when we say inversion. But again, for a high percentage of our spine patients, they really get some significant relief from it. The traction helps to allow the disc to kind of fill up with fluid, so to speak. I think disc degeneration is implied in pretty much all of us. That's just kind of a natural. I like to say the body's a consumable item. Well, there's not a rich blood supply to our disc from the top of the spine down to the bottom. So that said, we all lose fluid content in the disc as we get older. The discs get, degenerate, they get smaller, the vertebrae get closer to one another, and that prompts compression a lot of times on the nerve roots that exit, and that produces a lot of the pain that we deal with, that we all experience. But it's a way to help nourish the disc. And I do find the vast majority of our patients who have spine issues that are candidates. There's a few things a few types of pathologies in the spine that would be contraindicated for that type of therapy, but the vast majority will get some relief out of it, sometimes sustained relief, and they get better. So
yeah, what really makes it what Jimmy's talking about is this compression of the body that's related to the disc degeneration, so they start to collapse. But you got to remember, gravity is what you're working against. So what's above me is miles and miles of atmosphere that is squishing down on my body, and so we naturally get shorter if we're upright, subtly. When we're standing, sitting is bad, and then when we lay down, things tend to relax. And so the distraction or the traction or the decompression is basically an anti-gravity type of treatment. It also stretches the spine a little bit to make those narrow holes more open, at least temporarily, because once you get back up and gravity affects you again, we squish back down. But it's kind of like an accordion that we're trying to keep mobile, and if we can reduce the irritability that's created by that compression, people can feel better. So it's not a tool that is a cure of the baseline problem, which is typically just the wearing out of the body parts, but it's definitely a management strategy that can be very helpful in the right patient. There is some people who don't tolerate inversion, and people who have cardiac problems, people who've had stroke, people who have blood flow problems probably need to talk to their doctor about whether it's safe for them medically to trial being upside down. But that's a tool that's relatively inexpensive and accessible to people at home for ongoing maintenance as well. And so I think that's a booming industry as far as what we see out there for people.
Absolutely.
Yeah.
A lot of patients ask about it, and then the ones that benefit from traction, like Doc said, there's a lot of these issues are structural. They're gonna rear their head from time to time. So if you can manage it, like I tell folks, your goal should be to keep people like me out of your life as much as you can. I mean, realizing that we're probably necessary
Really,
from
you
time
want
to
to keep
time.
me out of your life.
But it's, you know, that said, that's one of those tools. If you benefit from traction, then it's worthy. Like Doc said, there's some exceptions in terms of medical issues that people deal with that might not make that a good idea. But the folks that benefit from our traction, you know, when there's structural issues, those show up in an X-ray, MRI, you know, in our diagnostics that our doctors do. That might be a worthy alternative for them. So.
And yet these are, fortunately, several of these things are available at home. So if they work for you, we can help you get set up and figure out how to have the physical therapist style of treatment, but at home. And many of those are very beneficial. So it's worth exploring if you have these type of longer problems that seem to be managed with these tools. Well, that's awesome. I think that pretty much covers it. Is there anything out there that you would call snake oil that you would say, you know what, it doesn't make much sense, or there's no data to support it, that is a commonplace kind of item out there? Anything that you would caution people about laying all of their eggs in that one basket?
I don't, not anything that I've been approached about. I mean, we will have people that anything that's new and innovative. There's not anything that we've been approached about by people that are trying to sell it. You know, we are bound to some degree by what our insurances will recognize as modalities that have enough research that say they do what the people say they do. So that does affect us a little bit. Dry needling is new. Relatively new. It's not new, but I mean it's one of the newer interventions that we have. My understanding is there really aren't any insurance companies that are recognizing that. They're actually reimbursing for that. Like, so in our office, and I'm sure others, that's something that would be an out-of-pocket expense. That said, I think, you know, the biggest thing for me is if it seems like it's too good to be true, it probably is. We utilize intervention modalities every day, and I think by and large they're helpful for the purposes that we use them. But I've not found the magic cure. You know, I guess over the years I've seen enough folks and worked with people, and I feel like I've got a decent idea of what hopefully works and helps people to truly get better. And I think generally that's going to be the more active things that we do. The more active, the more hands-on things. Again, I don't want to say that's the meat and potatoes, but I think it really is. But, you know, you need dessert sometimes too, and dessert is helpful. Sometimes these modalities help us to further achieve what we want through the active parts of our therapy. So.
And one last thing before we kind of close that I'd like to remind people is that in many cases, particularly certain types of surgical cases, physical therapy postoperatively is actually as important, or sometimes even more important, than the surgical treatment itself, because the outcomes that people get really depend on their dedication and adherence to the therapy protocols. You can screw things up if you don't do things like instructed, or if you don't go to therapy. You can waste your time and energy and money on a surgery that, if you don't intend to do the work, you're not going to get the benefit that we would hope you would get. And so it's important for people to listen to their physician, listen to their therapist. There are guidelines and step-by-steps for a reason. Just because you feel great doesn't mean it's necessarily true that your rotator cuff is ready to start lifting weights at 2 weeks after surgery. And you really have to listen to the therapist, to your physician, and hear what they're saying to get the best outcome that you can get. We can't guarantee an outcome because we're dealing with biology, which is 100% variable, but we want to maximize your ability to come out of whatever it is, an injury, a surgery, a malady. We want to maximize your benefit. We want to make it worth your time and money to do that. And in that regard, it is important to listen to the therapist, listen to your physicians, and understand why. So ask questions. Why is this important? Why shouldn't I lift weights 2 weeks after a rotator cuff repair, these types of things. And that's where an intelligent, educated physical therapist team like we have is really vital. The internet can't give you that. And so you've got one body, there's no substitute, in my opinion.
Yep, absolutely.
Any last thoughts?
Well, I think don't be afraid to ask if you're working with therapists, and I think it's a reasonable question to ask of your physicians too, but the why is make sure you understand why you're asked to do certain things or why you're told not to do certain things. I mean, I get made fun of because I talk so much in the office, but I've found that helps me connect with patients, being able to answer those questions. And then we can't answer all of them. I just an hour and a half ago I had a patient that was, we talked about communication and making sure that they ask those questions. And I always also encourage that patient to ask the same question of the physician. You're going to feel better hearing it from the surgeon than you are the therapist. You're probably going to get pretty good symmetry with that. We're lucky that we get to communicate with our doctors anytime we need to. But don't be afraid to ask why. And because that said so is not a reasonable answer. Don't be afraid to ask that question, and it should be offered anyway, in my opinion. But on my end, I ought to automatically let that be a part of my communication with patients, and I try to do that. But don't be afraid to communicate with them, and if they tell you to do something, it's okay to ask why.
Yeah, and if you don't understand, ask again. We know what we're talking about. At least we know what's in our head. We think we know what's in our head. And sometimes we're not good at getting it to a place where you can understand. So hold us accountable. It's important because it's your health. Anyway, Jimmy, thanks again. It's good to see you. Think of another topic. We'd love to have you back.
Okay.
Always good to see you. Everybody, take care. Appreciate it. Go online, TOA.com. You can learn about our therapy programs, our imaging programs, our physicians, our locations. We have a rich library of medical information in our media center, and our team of people who work on social media are incredible. She's right here, so I can say that. And again, thanks for watching. Thanks for your interest. If you have any questions, comment below. We'll try to get to them. If you have any topics you'd like to think about me bringing up, comment below. I'll be here next week. We're going to be talking a little. We're going to fine tune what the topic is, but we're going to be talking about back pain, and not danger type of back pain, but the run-of-the-mill. Everybody's got it, back pain, and why. I've got some insights there that hopefully can give you some information and make it less scary. Anyway, thanks again. Talk to you soon. Go out there, live your best life. Be safe. Don't slip on the ice. Take care.